And it's another great day here in the neighborhood at www.radio-next.tv. Jumbo Love, Cool Groove Radio in the Senior Scoop. And as always, we are proud to bring the discussion of sleep disorder, those things that might not seem paramount, but they really are. Dr. Anna Kute, our sleep specialist, is in with me again. How are you, Queen?
I'm good. How are you, Harold? It's good to
Harold is
be here.
doing quite well and trying to learn some of the techniques of healthy sleeping. And as I told you, I'm just trying to check them off one box at a time. And
Okay.
I've been doing better at setting myself up, Dr. Anacute, truthfully understanding before I go to sleep to reduce my stimuli. No, I think that's my biggest problem because I'm hyped all the time. My mind
Yes.
is rolling. So, listening to some of the things that we discussed, and we're going to talk about today the natural causes of sleep disorders. But one of the things that you have been so eloquent about displaying is the fact that you have to wind yourself down before it's time to take some sleep. And I used to go to bed with everything on my mind. I'm trying now before I go to sleep to say, okay, Jumbo, start shutting this thing down. At least recognizing it. Maybe not fixing it in the first week, but recognizing. So
Mhm.
thank you for that. But as I mentioned today, we're going to take about 15 minutes. And what I want to do is go into, we have captured so many different elements of sleep disorder and the natural cause of sleep disorder. I think we need to discuss. And one of the things we really haven't talked about, and I have talked to you candidly about this osteoarthritis in both of my hips and the pain. So let's talk about physical illness and pain, which is something natural that the person can't prepare for as they go to bed, but it happens. And then, if we have pain, if we have some type of physical illness, how
Mhm.
should we address trying to get a healthy night's sleep?
Yes. And that affects a lot of people, unfortunately, as people age, right? They start getting pains at their back, on their hips, and it becomes very difficult for them to find a good sleeping position, right? They're like, I turn to the left and my hip hurts and all of that. And what I always say is that starting out with reaching out to your doctor, your primary care doctor, about that pain and addressing it is one thing, right? Um, and things as little as over the counter Tylenol can be helpful at night. Just take 1 to 2 tabs at nighttime. And always go through with your primary care about that. Make sure that's okay and there are no issues why you should not take that. And so that can help during the night when it's difficult to find a good position to sleep. And the other thing is, yes, when you wake up also from the pain, are you able to fall back asleep easily? Okay, because yes, the pain can wake you up and you maybe take a tablet and you feel better. And then what happens after that? Are you now dealing with insomnia of your mind racing? And now it's no longer about the pain, it's now about you just can't shut your brain off to fall back asleep. So I still also talk about addressing the baseline insomnia if present, such that people are armed with what to do if they wake up in the middle of the night and they're trying to fall back asleep quickly.
You hit on something so dynamic because the pain might wake you up, but then many of the things that we discussed already, your stressors, you
Right.
start worrying. You
Mhm.
don't even know you woke up from the pain, and now
Yeah.
you can't go back to sleep because of the things that are the outside influences. So now we're blending, as we were mentioning. That's the reason, I was so excited to talk about this. We've got the natural cause of pain, but then we have the outside influences. How do we? Or is there a way to, I guess, if we're conscious of it,
Right.
say, okay, I woke up in the middle of the night. You don't really know it was the pain that your brain said, hey, man, wake up. You're sleeping in the wrong position and we're hurting right now. This body's hurting. But now we can say, I've learned enough from Dr. Anakute, Dreamland Health and Wellness to know the practice of trying to get back to sleep. What can we do once we wake up to get back to sleep?
Good question. And I always say that if you wake up, give yourself at least 15 minutes to see if you can fall back asleep, 15 to 20. Okay. And if you cannot, because beyond that timing, it no longer becomes healthy for you to stay in bed, because what's going to happen is that you're going to start looking at the clock and getting worried about how you've not been able to fall asleep. So I recommend to get out of the bed.
No, this is real stuff. That's what I'm telling you.
Yes.
I'm
And
sorry.
if
This is so real because this is me. This is me.
for my patients that struggle with watching the clock, I tell them to take the clock out of the bed. If that brings up more anxiety than necessary, I say, okay, that's fine. Leave your clock in the room, but I want you to turn it the other way around. So you're not seeing the time ticking and getting worried. Oh my goodness, I'm not going to fall asleep again. Because once that process kicks in, you already wake yourself up because your thinking and the brain centers are turned on, and that becomes difficult for it to get turned off. So I always say, get out of bed, sit in a chair, turn on some little lamp, and see what else you can do. You can listen to a nice, relaxing podcast. You can read a boring book, an uninteresting book that can make you feel
I
sleepy.
love
But really nothing engaging. And of course, nothing that gives blue light, nothing that stimulates you, nothing that wakes you up. I have patients that say, oh my goodness, I wake up at 2 a.m. and I wait for 15 minutes and I can't sleep. Then I go start doing dishes and laundry and making my bed. And I'm like, no, you cannot do that, because that's waking you up all the more. So you want to choose something that is really relaxing that you can do outside of bed. And then you start dozing off, and then you can get back in bed and keep sleeping. The goal at that time of the night is not to get anxious about the fact that you're not going to fall back asleep, one, and also not to engage in anything that stimulates you or causes some hyperarousal in the middle of the night.
This is a great topic, and we have so many more to discuss, but we could almost go 15 minutes on this because now we're incorporating. No, seriously, we're incorporating now, as we mentioned before, if you're living and sleeping with your mate, if you're married or if you're living together with someone, this is going to be a whole nother element of that. That whole dynamic, and so that's the reason I'm happy. But I do want to shift now because I had the pleasure of doing one-on-one therapy with autistic children. And
Mhm.
then many of the things I do as far as community awareness is dementia and Alzheimer's awareness and mental health. We have not discussed mental health and sleep. Not how it only affects the person that is diagnosed with the disorder, but the
Right.
family members who have to live and be alert about that. Let's talk about that.
Yes. So mental health is a huge topic and covers a lot. Things like depression, bipolar disorders, schizophrenia, and all of that. And those groups of people have a really difficult time falling asleep. And that also tends, like you say, to spill over to family members and caregivers who are taking care of them. Um, and the first step is always to start with the basics, right? There has to be the baseline sleep hygiene. Because if that's not there, other things will continue to, perpetuate the insomnia or difficulty staying asleep, right? And we're talking about little things like turning off the screen 2 hours before bedtime, taking off electronics from the bed. Sleep hygiene must be in place. That must be the
Hmm.
background. Because if those are not there, again, it's like you're treating, okay, yes, we know there is baseline mental disorder, but you have to take care of those little things in addition to that patient maybe going through therapy and all of that, or being on medications to help. Because Again, medications are never the first line for struggling with staying asleep, which is insomnia. The first line is what we call CBTI, which is cognitive behavioral therapy for insomnia, right? That's always the first step. And that is just a nice fancy way of saying behaviors, changing your behaviors and changing your cognition, your brain, what you're thinking about sleep, which are all these little tips that we've been talking about. This is not to say that this group of people should not continue therapy, should not continue their medications, but they want to also know that relying on medication to help them stay asleep is not supposed to be the end goal. The end goal should be that they're able to fall asleep and stay asleep when they can. And all of this should happen under the guidance of a provider, right? A doctor should be involved in taking care of them. If it's beyond the primary care, the scope of a primary care physician, then they should seek to be seen by a sleep physician to further manage the sleep disorder.
This is, I told you, this is compelling because everybody who is listening, somebody is going to have one of these things that are affecting, their sleep or lack thereof. And that's the reason I'm so excited is to continue dialogue about this. We've got about 5 more minutes, and we have touched on some of the things, but professionally, I would love for you to explain again the hormonal shifts, especially those in women. Then we want to talk about age. Uh, we haven't talked about this much, but going into genetics and family history, and then we'll end it on changes in your body clock, your changes in your schedule, and how that might affect you and your healthy sleep and rewind
Yes.
it down. So the first one, hormonal shifts in women, Doc.
Hormonal shifts in women. I can tell you countless times that I've had patients who just hit menopause and everything changes. And thankfully, these days we have hormone replacement therapies that help. And so when women get to menopause, there will always be changes, and this includes sleep difficulties, sleep maintenance difficulties. Sometimes sleep apnea becomes more prominent in these kind of patients, and not what I want for this group of women to do is to ask for professional advice. Go see your doctor. Don't just say, oh, it's menopause, it's going to go away, because
Good
it's
luck on that.
it's going to go away. No, it could be that you now have sleep apnea and you need to treat it, and that can help you. It could be that you now have insomnia and someone can treat you and that can help you. But there are little things that could be done, like if at nighttime, if they're really feeling hot, they can change out their sheets. They can lay out a pair of extra clothes that they can change into if they're drenched in sweat. Little things like that can help make life easier at those times. It is a difficult time, and honestly, yeah, it
I'm
is.
just thinking about it from the brother's perspective, just to hunker down and go along for the ride, basically, because you don't
Yes,
really have too much choices. You
yeah.
know, Realistically, and we want to shut this down, and we already talked about age, and I think that's pretty relevant
Hmm.
as we grow older, especially men. We know that sleep and worrying, diet, all of this contributes to the lack of. But let's close it out with genetics and family history because it's not a thing that we talk about a lot as it relates to you and your sleeping habits, but it's relevant.
Yes, so family history is really crucial. Everyone should find out what kind of sleep disorders their parents had, their siblings have, because that's what helps you to know, okay, what's possible. right now? What could be the issue why I'm not getting good sleep? And things like sleep apnea, restless leg syndrome, things what we call parasomnia, which is a big umbrella for activities in sleep, like sleepwalking, sleep talking, sleep eating, right? Some people eat in their sleep. And these things run in families, right? People have committed crimes because they did something in their sleep that they didn't even know about, that could have been caught by a provider and treated, right? And so finding out what happened with my siblings, with my parents, and what should I look out for, what should I be on the lookout for, is very crucial. And having your doctor learn about these, tell your doctor when the doctor is getting a history, and say, oh, this is, you know what, when people are asked for family history, they're only really thinking about diabetes, hypertension. Nobody's thinking about sleep apnea. By the way, my dad uses a CPAP machine. So it's always good to mention that, oh, my mom had difficulty staying asleep. My mom has insomnia. Oh, my mom's legs always bothered her. She had restless leg syndrome, things like that. Help your physician. And we're having this session so we can teach people how to advocate for their health, right? If your doctor is missing a thing or two and you are saying this is what is going on, that helps your doctor to look in that direction. And if they can't take care of you, then they can send you to someone who can help take care of you.
Like Dr. Anakute.
I love it.
No, they're serious. I mean, because and that's the reason that I told you I am so excited, because there might be one person that hears this and gains this knowledge that you are providing, that did not know that this was the problem they're experiencing, and now they are alert and can go consult with their physician to get the proper treatment. You know, as simple as that, Doc.
Right.
And as always, thank you. And if you want to learn more and find out more about to get some of this expert advice from Dr. Anakute, you can go to Dreamland Health and Wellness, or you can go to dreamlandhealth.com, or stay tuned here right here at www.radio-next.tv and learn more about you and your sleep. Thank you, Doctor.
Thank you, Harold.
Have yourself a great day.
Thank you.
Uh huh. Okay, we're done. Thank you so much. That was good.
Okay, very
That
nice.
was good. So I will send that over this afternoon. I will
Okay.
be putting it on the senior scoop today